Are well understood, but risk to the bystanders are often overlooked. High-speed debris causes severe ocular injuries. So why this study? Brush cutter injuries are underreported, with limited studies focusing on injuries to the bystanders. And bystander risk is poorly recognized, even though routine roadside and domestic brush cutting exposes the public to these types of projectiles. And severe but preventable injuries highlight the need for better safety protocols, since current awareness and protective measures are inadequate. So aim of my study is to highlight the vision-threatening injuries caused by these brush cutter debris in non-operators and emphasize the safety awareness. So it is all patients with globe injuries related to brush cutters were included in a duration of 18 months, done in a secondary eye care center in North Kerala. It's a retrospective consecutive case series of 8 patients. So we took a detailed history, comprehensive eye evaluation including vision, anterior segment evaluation. Dilated fundus evaluation, B scan and CT scan were performed in selected cases. So this is a push type brush cutter, operates using an engine that converts fuel or electrical energy into rotational motion. These machines are typically powered by gasoline or electricity and enabling the cutting blade to spin at a high speeds for effective vegetation. So this is the cutting system of the push cutter, typically comprises a rotating shaft with 2 blades. So once the power is on, this is converted into rotational motion, causing the blade to spin at a high speed, which is causing efficient cutting of grass and vegetation. So my results in 8 patients with 2 operators and 6 bystanders. 4 were open globe injuries and 4 were closed globe injuries. All the operators were wearing protective eye gear, whereas none of the bystanders wore eye gears. And the patient 1 and 2 were operators. They had a closed globe injuries with good vision, and one had corneal abrasion, which was treated with antibiotics and lubricants. The second one had a corneal abrasion with a small iridodialysis and a partial thickness scleral tear with a foreign body, which was removed through a partial thickness scleral tunnel. The patient 3 is a 21-year-old male. He was just passing on a bike and he got injured by a stone from the cutter machine, and he had an open globe injury, and we couldn't save his vision even though we performed a primary globe repair. The eye went into phthisis and we had to give a prosthesis later on. Patient 4 was just watching the procedure being done in his home, and he had corneal abrasion, hyphema, and angle recession glaucoma later on, and subluxated cataract. He is waiting for cataract surgery and now on anti-glaucoma medications. Patient 5 is a non-operator. He was in the nearby shop. He even didn't know the procedure was being done at a nearby compound, and he had a closed globe injury with a partial thickness tear and a subluxated cataract lens, and he underwent a pars plana vitrectomy and iris clay oil implantation. And patient 6 was a non-operator. He was just passing on a bike, and he also 28-year-old male with a PL negative with a traumatic globe rupture. And patient 7 and 8 were bystanders watching, and they also had a very poor vision with a traumatic globe rupture. So this is one of my patients with intrascleral foreign body. So this was removed through an intrascleral tunnel. And this is the first patient I showed, 21-year-old male with a globe rupture, and he went into phthisis and we had to put a prosthesis. And this is, you can see the patient with a subluxated cataractus lens, and he underwent a lensectomy and vitrectomy and iris clay implantation. So coming to discussion, globe injuries are ocular emergencies that demand prompt medical attention, especially when they occur in the context of a workplace trauma, with open globe injuries with very poor visual outcomes. And the resultant visual impairment not only affects the individual's quality of life and earning capacity, but also it gives a significant emotional and financial burden to their families. So we all know that in our case, it is all the patients were males who are the earning members of the family. Even occupational injuries are 79.1% is reported in young males. And in our series, open globe injuries, 4 cases had poor visual prognosis despite timely management. Open globe injuries are one of the predictors for permanent visual loss reported by Agarwal et al. And 2 of our non-operated globe injuries had good visual outcomes. Subluxated cataractus lens with had a good visual outcome. Even study showed that in a closed globe injury with severe subluxation, if you do the surgery at the right point, lensectomy and vitrectomy, and with the iris clay implantation gives you good visual outcome. And in our case series, also the grievous injury was sustained by the bystanders, not the patient, means a person who is doing 75%. And a Thai study also reported similar, but there 20.9% only, we had a high number. So urgent need for policy level intervention to address the risk of ocular trauma, not only among brush cutter operators, but also among the bystanders who remain inadvertently exposed needed. So preventive strategies could be at the level of the physical level and at the regulatory level. Physical level, mainly engineering controls like a PPE for an operator, debris guards and safety zone. And regulatory, you can have legislation and enforcement, and behavioral strategies like training and user training programs. So what we know is brush cutter and grass trimmer tools can cause high velocity projectile injuries, often vision threatening. Most reported cases involve operators, and bystanders injuries are underdocumented. Open globe injuries generally have poor visual outcomes, while many closed globe injuries recover well. What my study adds is it shows equal or greater risk to bystanders with injuries occurring during routine daily activities, demonstrates serious vision threatening outcome including globe rupture and angle recession glaucoma, highlights an unaddressed safety gap, absence of safety zones, and lack of public awareness near brush cutting activity. And in the future, implement mandatory safety radius and energy controls for brush cutters and strengthen the community awareness so nearby individuals avoid exposure, and larger multi-center studies to better define this bystander risk pattern and preventive strategies would be beneficial. Thank you.
In Remya. And second thing is, definitely this is a retrospective study. So you have only 2 patients and 6 bystanders, right?
Yeah.
Okay. So then the number of patients you may have seen is less.
Yes, ma'am.
Your samples is less.
Yeah.
So have you checked whether any of your colleagues in an other part have got this
No, I
sample
had to see
size?
that.
You are from which part of Kerala?
Kannur.
Okay, so only in that area is this brush cutter being used, or all over Kerala it's being
Actually,
used?
it's being used everywhere, but we have to see how many are getting these types of injury. I had quite a number of cases in the first 1.5 years, almost 8 numbers. I have to see.
So is it that they are using a new modality of because someone standing in the shop who is unaware of it is also getting injured, right?
Yeah.
So you need to know. You can't ask everyone to wear the
That's what a
glasses on the
safety
road
radius.
also.
The safety radius government should implement a policy so that this much amount of radius nobody should be there. So otherwise, it's difficult to wear protective wear.
Exactly.
Yeah.
Wear for all on the
Yeah.
road. So that is one thing. And second thing is, if you had taken more sample size, it would have been
Yeah,
beneficial.
definitely.
With 8 patients, we can't speak to the public, right?
Yeah.
Other eye in all these patients.
Yeah, ma'am. Other eye had none of the patients. Other eye was normal actually.
What do you expect in the other eye actually?
Yeah, traumatic. Other eye. Sympathetic ophthalmia.
Yeah, I think
A
because
long-term
all most
follow-up.
of
Yeah,
these,
we have looked for it. We used to call the patient every 3 months, but nothing had. Means nobody had sympathetic.
and there was no other infection also because it involves vegetable matter as well. You know?
Only that intrascleral foreign body, it was not gone inside, so the patient had very good vision even after the removal. So it was just intrascleral, so just scleral tunnel, and we took out the foreign body.
Thank you.
Thank you.
So I next call Dr. Rehina Ibrahim Gutti for the presentation. Good morning all. My paper is on retinal OCT biomarker in acute CRAO, its correlation with severity and disease stage. So CRAO is an acute ophthalmologic emergency analogous to CNS stroke or sudden profound painless vision loss due to the acute ischemia of inner retinal layer. So the role of OCT is OCT revolutionizes the retinal imaging, which enables detection of microstructural changes that not visible clinically. And the typical finding that's seen in acute CRO is inner retinal hyperreflectivity and retinal thickening. And recently, newer OCT-based changes have been included, that is prominent middle limiting membrane sign, loss of inner retinal layer stratification, inner retinal layer thinning, IRF, SRF, and ILM detachment. Relevance of these findings in clinical practice is unsure. So my aim of my study is to evaluate the OCT biomarker in patients with acute CRAO and correlate their presence with disease severity and staging, and also to assess the prognostic value of these OCT features in predicting visual outcome. It is a single center cross-sectional retrospective study conducted in acute CRO cases who attended in a tertiary eye care hospital between January 2022 to January 2025. We included diagnosed case of acute CRO, those who have available SDOCT within 7 days of symptom onset. These are the data we collected from their MRD. And this is the criteria we used for classify the CRIO cases into mild, moderate, severe. This is based on a previous literature review. We used the inner retinal layer opacification, thickening, and a loss of stratification to classify into mild, moderate, and severe cases. The other parameters we analyzed is PMLM sign, IRF, SRF, ILM detachment, prominent RPE, intraretinal HRF, vitreous clump, inner retinal thinning. Compared it with the OCT severity scale, correlate with vision and analyze for resolution and persistence. So total our study sample is 38. Out of this, we are classified into mild, moderate, and severe CRIO. In our study, 52.6% cases are severe CRIO. And these are the demographic detail that distributed among the mild, moderate, and severe CRIO. The only statistically significant factor we noted is that time of presentation from symptom onset. That is more in the severe CRIO case. That is p-value significant there. This is the comorbidities that distributed among this population. Out of this, hypertension was the commonest risk factor we identified, and there is no statistical significance found that. Then presenting visual acuity. In our study, they show a wide range of presenting visual acuity in mild, moderate, and severe CRIO. And this visual acuity grade did not correlate with the CRIO severity based on the OCT. These are the findings we looked in our study, that is prominent middle limiting membrane sign, the inner retinal hyperreflectivity and thickening, the prominent RP, foveal RP hyperreflectivity, ILM detachment, vitreous clump, hyperreflective foci, presence of IRF and SRF. Out of this, we analyzed each these findings in mild, moderate, and severe, and we found that the prominent middle limiting membrane sign is predominantly found in mild and moderate case of CRIO, and also present in severe CRIO cases. And even two factor, that is, even though statistically is not significant, like ILM detachment and IRF. ILM detachment is only seen in the severe cases, and IRF is predominantly seen in severe case. So it is implicating of a poor prognostic OCT biomarker. So these are several OCT in our study population, indicating one of the mild CRIO cases with inner retinal hyperreflectivity and a PMLM sign. This is indicator of moderate CRIO, inner retinal hyperreflectivity with the thickening. This is another severe CRIO, inner retinal hyperreflectivity, thickening, and loss of stratification. And these are the several findings we found in our study population, that is ILM detachment, posterior vitreous clump, IRF, and SRF. Final visual outcome, there is no statistical significant association was found between initial CRIO severity and final visual outcome. So in our study, both the presenting visual acuity and the subsequent visual outcome does not based on this OCT severity biomarker. So discussion, in our study, there is a higher proportion of severe CRIO cases are there, which may be due to the referral center bias, delayed presentation, or demographic differences. Another finding is that onset to presentation time increased with severity in our study, that is statistically significant, that highlight the need for early detection and referral. Other finding like higher mean age group, male preponderance, consistent laterality, all are similar to the literature review. Does the OCT-based classification impart any prognostic value to the clinician? Previously, Venkatesh et al. Reported that visual acuity deteriorated with increased severity based on the OCT. But in our study, we found that the severity of CRIO did not correlate with the presenting visual acuity. Also, the final visual acuity was not reflective of baseline OCT grading. So, vision in CRIO patients are probably influenced by other factors and not these structural findings on OCT. Do specific OCT biomarker have some prognostic implication? Yes, that is prominent middle limiting membrane sign, which is high in mild and moderate case when it is compared to severe cases. So it indicating of a good prognostic sign. And another two findings are ILM detachment and IRF, which is predominantly seen in severe cases. So they are of poor prognostic value. Other OCT factors does not have any significance that is similar to the literature. So conclusion, the CRIO severity correlate with specific OCT biomarker, especially the prominent middle limiting membrane sign, presence of IRF and ILM detachment, and there is no consistent link between the initial severity and final visual outcome, highlighting the need for personalized care, which emphasizes tailored therapeutic strategy rather than severity-based predictions. These are my limitations. This is a small sample size cross-sectional study. For better result, we should extrapolate this study into a multi-center cohort and for better analysis. These are my references. Thank you.
Thank you, Doctor. It's a very good presentation and good thought process. So, very able to, it's good, very able to match the time of presentation with the OCT. Did you
Yes.
make any variable out of it? Because that can also possibly cause a difference in the outcome. Yeah.
Those who presented early have mild and moderate severity. That may progress later into severe. So timely management is very important in case of CRA cases.
Okay. So you have not exactly correlated the severity of the OCD findings with the
Yes.
times temporal sequence. The other thing is, for the future, you may also have to correlate it with the etiology, because the severity of the CRAO may be influenced by the underlying pathological process. So you have not looked into it now. Probably in the future, you should be able to look into it.
Very good presentation. So has serial OCT been done also? Like the same
Several,
patient?
most may about our total population 38. Out of these, 33 patients have a follow-up OCT. So serial on follow-up, they show a retinal thinning most of the time. Some mild cases show improvement in their vision, and more severe cases persisted like that, and some get worsened.
So the biomarkers will be mainly on the first OCT.
First dose.
Okay. Thank you.
Next presenter is Dr. Marian Poli. Good morning, respected judges. My paper is on outcomes of socket reconstruction involving multiple surgical interventions. So in September 2012, this 9-year-old male child presented to me. He's a known case of bilateral retinoblastoma, right eye status post enucleation with a ball implant at 2 years of age, extruded implant and dermis fat graft done elsewhere. So his father came and asked me one relevant question: will my son be able to look normal or near normal ever in his life? So this question intrigued another question in my mind. In this context, I did a study to analyze the outcome of socket reconstruction in patients requiring multiple surgical interventions, highlighting both the challenges encountered and the strategies employed to optimize functional and aesthetic results. It was a retrospective interventional study from 2012 to 2025 at a tertiary eye care center in South India. All patients who had undergone 2 or more surgical procedures, excluding the primary surgery, were included, and those with less than 6 months follow-up were excluded. Demographic details: etiology of primary or secondary anophthalmia, type and number of previous socket surgeries, indications for repeat reconstruction, intraoperative findings, surgical techniques employed, such as dermis fat graft, mucous membrane graft, AMD, adjunctive procedures, which includes fornix deepening, sutures, ptosis correction, and tarsography, were analyzed. Patients were followed up at 1 week, 6 weeks, 6 months, and yearly thereafter. The primary outcome measures were socket stability, prosthesis retention, and fornix adequacy. Secondary outcomes include complications such as graft failure, implant exposure, infection, or persistent volume deficiency. Surgical success was defined as a stable socket that could comfortably retain a prosthesis without the need for any further major surgical intervention at final follow-up. Cosmetic outcome was defined in terms of symmetry, appearance, and patient satisfaction, and graded on a scale of 1 to 3, ranging from good, fair, and poor. Coming to the results, we had 15 eyes aged 5 months to 58 years. Males and females were almost equal. The follow-up ranged from 6 months to 12 years with an average of 3.1 years. On analyzing the primary pathology, 4 had intraocular tumors, 4 with infections, 4 patients had congenital anophthalmia or microphthalmia, and 3 had trauma. Coming to the primary procedure done, 40% had undergone enucleation without implant, and 33.3% underwent multiple procedures. Surprisingly, 80% of patients presented to us for secondary or tertiary reconstruction following the primary reconstruction done elsewhere. Coming to the surgical procedures done, dermis fat graft was done in 40% of cases, debulking in 33.3%, and secondary ball implant in 33.3%. Other procedures included canthoplasty, full thickness skin graft, tarsography, etc. The total number of surgeries per patient ranged from 2 to 4 with an average of 2.7 interventions. So this is another child, 4 years, with a known case of congenital anophthalmos, status post dermis fat graft and canthoplasty done elsewhere. She just presented to me at 4 years, and I did horizontal PFH lengthening with the medial canthoplasty and lateral canthoplasty at 4 years. And this was the post-operative outcome. However, parents were not very happy. So after 11 years, she underwent reconstruction in the form of full thickness skin graft, mucous membrane graft, canthoplasty, and lid crease formation. And this is her picture at a final follow-up. So we had 100% surgical success, that all the patients retained the prosthesis at final follow-up. Cosmetic outcome was good in 80% of patients, while 20% had a fair outcome due to suboptimal cosmetic recess. No major long-term complications were noted. He is a 46-year-old male, status post RTA, frontal bone fracture, total ptosis and physis bulbi. So initially he underwent fracture repair with a patient-specific implant, followed by volume augmentation with the dermis fat graft and ptosis correction with the frontalis sling. This is another patient who presented to us 18 months. Initially she underwent serial conformers, then followed by dermis fat graft at 3 years, but parents were not happy because of the proptotic look and squint. Later she underwent dermis fat graft debulking with the tarsography, and this is her picture at final follow-up. So now coming to our first patient. So this patient underwent multiple procedures. He underwent dermis fat graft debulking in 2018, followed by ptosis correction with the frontalis sling and lower lid retraction correction, and this is his final picture at follow-up. So coming to the discussion, this is a unique study where patients undergoing 2 or more socket reconstruction surgeries were analyzed with 100% retention of customized prosthesis with a good cosmetic outcome and no major complications. So analyzing the replacement of socket volume, dermis fat graft and secondary acrylic implant was the most common modality, and the choice of implant depends upon the condition of the fornix. If the fornix is short, better to go with dermis fat graft. 33.3% had undergone debulking, and all had undergone dermis fat graft in less than 5 years of age. Based on the standard protocol, we have to overcorrect dermis fat graft by 20% in adults and 10% in children. But based on our study in pediatric age group, it is better to undercorrect by 10%. However, this needs more volumetric analysis by imaging. So this is a child primarily presented to us with a congenital anophthalmos, underwent cystic excision, then followed by prosthesis, and later she underwent dermis fat graft and customized prosthesis, and she is at 10 years of age. Similarly, this is another patient, road traffic accident, ptysis. She underwent dermis fat graft for volume and later ptosis correction with the frontalis muscle transfer. So coming to the adjunctive procedures, 40% had ptosis correction. Ptosis can be multifactorial, either true ptosis or pseudoptosis or a combination, and the procedure also varies. Ariasit et al. Studied grade 2 to 3 contractures, and they have noted up to 1/3 of cases required additional procedures, mirroring our need for multi-stage reconstruction and lid surgery to optimize the cosmesis. So coming to the strength, we had complex cases with a long follow-up, limitations, small sample size with a mixed pathology. So what this study adds, importance of individualized multi-step surgical planning, problem-based approach in managing complex sockets. Patients need preoperative counseling regarding the possibility for multiple surgeries. A combination of surface expansion, volume augmentation, and lid correction provides a favorable outcome in restoring function and cosmesis in socket reconstruction. These are my references. Thank you.
Excellent presentation. Especially the cosmetic outcome is very good.
Thank you.
And in patients with who have undergone treatment for retinoblastoma, would you expect any unique challenges because of
Yes, ma'am.
Could you
Depending
elaborate?
on the primary treatment which they had undergone, if they had undergone radiation in the past, secondary reconstruction is really very challenging. So most of the time we reconstruct with the dermis fat graft once they're older. Even my first patient, he presented to me in 9 years. I did the reconstruction at the age of 15 years. So that was the major challenge. Wound healing can be a problem, especially if they had undergone radiation.
change your procedure in any way for this purpose?
Now I will try with the best procedure, volume reconstruction followed by other adjunctive procedures. If the volume reconstruction fails, then I have to counsel the patient regarding the complications, and you have to accept what you have.
Okay. And when we see like children referred at birth with like anophthalmos or something, so what is the first age at which they'll have to look at like an implant?
Uh,
When,
the-
when When would
first-
you recommend?
Yeah, initially I start with the surface expansion with the serially grading conformers, and by 2 to 3 years I'll go for volume expansion with the dermis fat graft. By that time they will have some fat to take from the gluteus to put it in the socket.
Thank you.
So she has asked all the questions that I wanted to.
Next, I shall call Dr. Latika VK for the presentation.
Good morning, all. My presentation is focused on this question of can lifestyle affect retinal health? And the study I'm going to present is on lifestyle related determinants of GCIPL thickness in South Indian adults. We all know that ganglion cell inner plexiform layer thinning can indicate optic neuropathies as well as neurological diseases, even if we forget retinal health. But what is unclear is what is the correct normative database of GCIPL thickness in Indian adults? What are its determinants in our population, and are there modifiable lifestyle related factors associated with GCL thinning in our normal population? So addressing these research gaps was the aim of this study, and the study was done in the hope that if we come across factors which are modifiable, it may be the first step in early detection and prevention of retinal neurodegeneration by it gives us an opportunity to implement appropriate lifestyle interventions on a large scale. So that would be an impactful aim of the study. After IEC approval, it was a cross-sectional hospital-based study conducted at a tertiary care hospital in central Kerala over a period of 18 months on by consecutive sampling of an adult population of 168 eyes were included, and all diseases, systemic, neurological, and ocular diseases that could affect retinal architecture, as well as factors which could affect OCT signal strength, were excluded from the study. Demographic data, systemic history of addictions, and digital screen time were recorded using a questionnaire. Thorough ophthalmic evaluation was done, including the anterior segment examination, IOP measurements, and a dilated fundus examination. GCIPL thickness was measured using the Ksos SDOCT macular tube ganglion cell analysis algorithm. So in this study, the mean GCL IPL thickness was 79.49 plus or minus 6.37, with males having significantly thicker GCIPL compared to females. And we also found that aging causes a significant thinning in this neuronally active layer of the retina. In fact, GCIPL decreased by 0.151 microns per decade. Patients with diabetes and hypertension with no retinopathy or other clinical features were included in the study. And both diabetics and hypertensive patients had a significant thinning compared to those who didn't have diabetes and hypertension. In fact, diabetics had 2.72 times odds of having a thinner GCIPL. Digital screen time of more than 10 hours came up to be a very significant factor introducing GCIPL thinning. Smoking and alcohol, contrary to our expectation, did not actually come out to be a significant risk factor, whereas tea and coffee drinkers surprised us because more than 3 cups tea and coffee drinking was associated with a thinning of GCIPL layer. So this is just a composite real-life picture showing different demographics. In a 60-year-old female with diabetes, hypertension, and these parameters, as compared to a 25-year-old male with no comorbidities, a 20 microns difference out of the 80 was actually demonstrable on OCT, which is quite significant. And this normative data obtained in our study is actually a little bit less compared to the other studies from the West and elsewhere in South India itself. And the differences may be due to geographic or ethnic diversity in some cases, whereas differences in inclusion criteria, because these other studies by Sundaram et al. And Elwan et al., both of them included diabetic retinopathy patients as well. So the inclusion criteria could have mattered there. And most of the existing evidences concurs with our observation that age, diabetes, and hypertension does cause significant GCIPL thinning. But we could not find any studies comparing GCIPL thinning and either digital screen time or addictions. So this is a cross-section study, but it provides very valuable research grounds for further exploration by identifying risk factors. Prospective community-based longitudinal studies for risk factor prediction are required in the relevant areas that are identified in the study. Digital screen time needs to be explored further in terms of the type of device, the blue filter, working distance, mechanisms of damage, etc. And to be frank, data was ambiguous regarding the beverage intake because patients did not remember whether they had tea or coffee, but most of them were having both tea and coffee. So studies focusing on exclusive cohorts of caffeine or tea addicts may provide further information. This is just some data that we got on a cross-section study. So in conclusion, the determinants of GCIPL thinning turned out to be age, female sex, diabetes, hypertension, and a digital screen time of more than 10 hours can significantly reduce normal GCIPL thickness from the 79.49 normative database in Indian eyes. Whereas, though tea and coffee drinking did provide some statistical significance, the clinical significance remains to be known through very longitudinal risk factor analysis studies. And what was surprising is that no GCIPL thinning was noted in the these factors which are known to produce actually neurodegeneration, especially in the context of glaucoma, sleep issues, snoring, etc., did not have any effect on the GCIPL. RNFL analysis was also done concurrently, and that too follows the same patterns by and large. So what this study adds is that diabetes strikes the ganglion cells first, even before it strikes the microvasculature and produces microvasculopathy. And computers and frequent SIPs are a wrong combo for the retina. So what the study actually adds to our understanding is that it's a reliable reference of normative data of South Indian population with specific reference to Kerala. Diabetic and hypertension and retinal neurodegeneration preceded fundus and OCT signs of retinal microvasculopathy. This is the first study in which digital screen time and caffeine have emerged as possible modifiable determinants of retinal neurodegeneration. And so it's recommended that this normative database should be borne in mind while interpreting GCIPL in Indian eyes, and it can be incorporated in diabetic retinopathy screening protocols. Prevention of lifestyle-related diseases and screen time less than 10 hours can promote retinal health, which is of contemporary relevance in the smart era, tech-based work culture and lifestyle, with all our youngsters glued to the screens all the time. These are the references. Thank you.
So, Dr. Latika, sorry, that's a very nice out-of-the-box study, but I have got some questions. One is, in a qualitative research, it's very difficult actually. The quantitative researches are much easier than the qualitative research. You have done a good job. So, did you check the visual acuity, like, whether any lens changes were
Yes,
there, Locke's
actually-
classification or something was used in this? And second is like, you yourself said that in the age, there is a, as age advances, there is a thinning of the GCL, right? So you won't be comparing young with the adults. So you have got separate analysis for young and
Yes.
separate analysis for the adults also.
No,
Was it done separately or you just compared as one? Because tea time in young, tea time in elderly population. So, age decade wise, have you checked?
Madam, regarding your first question, I excluded all refractive errors in the extremes of that's plus and minus 5 diopter and plus 2 minus 2 the cylinders were excluded because extremes of refractive errors themselves can cause GCIPL thinning. So that confounder was excluded. And visual acuity of 6 by 6 with BCV of 6 by 6 was included in the study. And regarding your second question, we actually analyzed the age in these class intervals, less than 30 years to 71 to 80 years class intervals. But the addictions we analyzed as an entire group. We did not go into the particular, because actually this being a cross-sectional study, we were actually surprised by the results. So I think we need to design focus studies on these areas.
To be a little more better classified.
In this one, that was not really, we did not expect this finding.
Expect
actually.
this, there's a surprise, right?
So what is the test retest variability in the measurements? Like how
This-
many times will you test each patient?
Once. It's a cross-section study, so we saw the patient once only. It was not longitudinal.
No, in the
and-
same patient, if you test 2 times, will you get 2 different values? Like there is a test, retest variability,
yeah,
right?
but
What is
this
that?
patient was only seen once. One patient was seen only once.
So you, okay, it is based on a single
yeah, it's a
measurement for
cross-sectional
each
study,
patient.
yes.
Comment. So in Alzheimer's, we have thinning of the GC-IPL complex.
Yes.
And myself being a voracious coffee drinker, I will not agree with this. So, so what they say is, I have not checked. So what they say is, good heavy coffee drinkers, Alzheimer's is delayed, and
Yeah.
dementia is delayed.
Mm.
So in that correlation, we need to relook at the data of coffee drinking causing thinning of GC-IPL. I would not agree with that.
Surely, sir,
So-
this is controversial. I
Yeah.
told it in my limitations also.
Yeah, that's
But
what.
this is, I mean, we have to look into it, that's all.
Person, please, Dr. Rakhi Pidicruz.
Good morning, everyone. Dr. Akiri Cruz, and I'll be presenting my study on optimizing conjunctivitis treatment, a study on preferred practice patterns in South India. So, conjunctivitis, commonly referred as by pink eye, represents one of the most prevalent ocular surface disorders globally. But the management of conjunctivitis varies substantially depending upon the perceived etiology, the clinical training of the ophthalmologist, as well as the regional healthcare practices. So, in many parts of South India, where the patient volume is high and access to culture and sensitivity is limited, ophthalmologists often rely on empirical management strategies. So, the primary objective of this study was to evaluate the effectiveness of these empirical management patterns across South India. And secondary objective is to examine the necessity of cultural and sensitivity testing and compare the prescribing behavior of general ophthalmologist versus cornea specialist. So this was a cross-sectional study, which was a questionnaire-based Google form study done over a 2-month period during the peak conjunctivitis season. This form was disseminated electronically via WhatsApp, institutional forums, and via email to consultant ophthalmologists across 3 Indian states, Kerala, Tamil Nadu, and Telangana. The questionnaire actually had questions related to diagnostic strategies, how they differentiate virus and bacteria, preferred first-line treatments, clinical decision-making regarding the use of culture and sensitivity, follow-up of the practices, and duration of therapy. Also, the influence of institutional guidelines versus a personal clinical judgment on the prescribing behavior. This form was pre-validated by a panel of 3 senior ophthalmologists. So we analyzed total of 77 completely valid responses from experienced ophthalmologists in South India, of which 47 were comprehensive ophthalmologists and remaining 30 were cornea specialists. Viral conjunctivitis was of course the most common encountered type. Diagnosis was primarily clinical with microbiological testing rarely utilized. Supportive care and lubrication was universally advised. Virus was nearly 80%. 80% of all the routine prescribed routine cases were prescribed empirical broad spectrum antibiotics. The most common one was fluoroquinolone, moxifloxacin, followed by aminoglycosides, macrolides, and chloramphenicol. And surprisingly, nearly 47% of the people gave a combination of an antibiotic with a low dose steroid as the first drug during conjunctivitis. So and now let's see how when they started to give. 40% of them initiated even before the appearance of SPK. Just on seeing conjunctivitis itself, they have started on the low dose steroid with antibiotic combination. 36% started after the appearance of diffuse SPK, and 24% of them delayed the initiation until the SPKs progressed to subepithelial lesions causing visual disturbances. The steroid use was varied in timing and dosage, reflecting that there is a lack of standardized treatment guidelines. Preferred low-dose steroid was loteprednol and fluorometholone. Prednisolone acetate was preferred in high potency in severe cases, hemorrhagic conjunctivitis, pseudomembranous conjunctivitis, diffuse SPKs, or anterior uveitis. Preferred drug in confluent pseudomembranous cases was Predford. Most common frequency given was 6 times, and clearing was noted nearly in a 10-day period according to the consultants. In the cases with confluent SPK with vision drop, majority preferred loteprednol, but all the cornea specialists uniformly gave prednisolone.
Systemic steroids was reported by 32% of the consultant, primarily in refractory cases. IV dexamethasone was practiced as a stat dose, followed by a 1 week of oral steroids by nearly 15 consultants. Antiviral ointments were used only by 30%. This was used on the appearance of SPKs. Acyclovir 5 times daily was preferred, followed by ganciclovir. Treatment was discontinued after approximately 1 month without any tapering. Majority believe that antivirals does not have any significant benefit. So the tendency of the ophthalmologist in this study to prescribe empirical broad spectrum antibiotic combined with a low dose steroid in viral cases contrast markedly with the evidence based common recommendation, which caution against the antibiotic use due to the self limiting nature of viral conjunctivitis and the concern about the rising antimicrobial resistance. Topical corticosteroids remain the important therapeutic tool in managing the inflammatory sequelae like viral conjunctivitis such as in SPK and pseudomembranous conjunctivitis, as stated by other studies also and as stated in our study also. The judicial use of low-dose steroids reduce the discomfort and visual morbidity associated with subepithelial infiltrate, but it actually needs a careful exclusion of herpes simplex virus because in cases of herpes simplex, it can lead to exacerbation. This is not being followed by many. And high-dose steroids were correctly limited to severe cases in our study also, consistent with recommendation by others, but always there is a risk of prolonged viral shedding with high-dose steroids. Despite the therapeutic benefit of antivirals, acyclovir ointment was given only by very few people, and acyclovir ointment still remains as the first preferred agent when herpetic etiology is suspected, as stated by Asari and Barney and Solano et al. Emerging treatment with a topical providone iodine formulation show a promising result in adenoviral conjunctivitis, but it is yet to be widely adopted. So my findings corroborate with the similar observation in international studies of conjunctivitis pattern, where overuse of antibiotic and steroids is driven basically by the diagnostic ambiguity and the clinical preferences. This current study states that there is a gap between the ideal and actual management, emphasizing that there is a need for a regional tailored protocols and enhanced diagnostic support with a simple testing like a rapid adenoviral testing for and ongoing provider education. So to conclude, the preferred protocol pattern from this study was use of lubricating eye drops in all cases and to introduce low-dose topical steroids only if complications developed. In all cases with severe pseudomembranes, hemorrhagic and conference SPKs, prednisolone acetate is to be preferred. Systemic steroids may have an advantage in severe non-resolving and prolonged cases, but current evidence is still limited and further studies are needed before incorporating them into a standard protocol. High rate of SPK seen in this study may be due to the inconsistent management patterns over use of steroids, emphasizing the need for a formulation of a unified context-specific treatment guideline. Thank you.
So, Dr. Raki, this is a good study. The only thing is you have sent questionnaires across South India, you said.
Yes.
You said you had cornea consultants, you had general practitioners also. So you know who gave steroids or who gave antivirals. You have that data. You didn't divide that as the responses from
47 were from comprehensive ophthalmologist,
Yeah.
30 were from cornea specialist. Just mentioned.
So that's there. But in the results, you have not said separately on who gave steroids or who gave antivirals as the initial
I
treatment.
had actually mentioned, ma'am, all the institutions are mainly sent to the cornea specialist, ma'am. So they preferred, most of them preferred mainly lubricants initial visit, and then they started low-dose steroids solely later. And very few had given high-potent steroids, and that too in refractory cases only. So that is my conclusion towards the end of the study.
So
to
what is the
follow that.
take-home message now?
That is the take-home message, ma'am. Better to give. First, try to differentiate the etiology. If you are very sure that it's bacterial, you can start the antibiotic. Otherwise, don't start it in the first go. Also, don't start an antibiotic with a low-dose steroid as the first drug. Start with the lubricant, follow up very frequently, and if you see that it is worsening, you can actually start a low-dose steroid. And in refractory cases only, you go for this high-potent steroids like prednisolone acetate.
Thank you.
Did the practitioners consider other etiologies like microsporidium and other things?
Yeah.
Had they considered?
Yes, sir.
Okay.
Few of them had considered about others.
Other etiologies as well. And also the timing of the presentation is important, especially with antivirals. So because it's most effective only in the first 48 hours of active multiplication. So it would have been interesting to know if the practitioners that considered that factor before starting antivirals, supposing the patient had come after 3 or 5 days. Possibly the antivirals would not have been effective, maybe.
Yeah, according to the, I had there was a question. When are you planning to start? When did you start antivirals? What time period? And most of them said after the appearance of SPK.
I think one of the most important thing is the parental counseling, because the viral cases will have a period of exacerbation and then only it will remission. So initially the parents will be very apprehensive. When they come, it will be very mild, especially if they come in the first or second day. Then there will be lead edema, and there will be worsening symptom, and then it will reduce. I think that pressure in the private is to keep them happy. So that may influence the line of management. But counseling is very important, I would say.
The next presenter is Dr. Karthika Mohandas.
Good morning. I'm presenting demographics of patients with posterior circulation stroke who primarily presented to the ophthalmologist. Posterior circulation stroke involving the vertebrobasillary artery system account for 20 to 25% of ischemic strokes. And unlike anterior circulation stroke, these patients present with non-specific or subtle symptoms, with visual disturbances being the most primary or sole complaint of the patient. And due to the visual symptoms, patients usually present first to the ophthalmologist. So early recognition of neuroophthalmic signs such as homonymous hemianopia and prompt referral for neurological imaging such as MRI and neurological consultation is essential for timely intervention and management and better outcome of the patient. The aim of the study is to evaluate demographic and clinical profiles of patients with posterior circulation stroke presenting first to ophthalmologists, to emphasize the importance of recognizing visual symptoms early, to improve interspecialty referral and reduce diagnostic delay, and to highlight the ophthalmologist's crucial role in stroke recognition. This was a retrospective chart review at a tertiary eye care center in Kerala, including patients presenting with visual complaints who underwent automated perimetry and had homonymous hemianopia on visual field testing. We excluded non-neurological causes of field loss, and data analyzed include demographic symptoms, ocular findings, visual field findings, MRI reports, and comorbidities. Posterior circulation stroke was diagnosed based on neuroimaging findings showing infarcts involving the occipital lobe, thalamus, brainstem, or cerebellum consistent with vertebrobasilar artery system. A detailed history and visual symptom documentation was done with comprehensive ocular examination, including visual acuity and fundus evaluation. Visual field testing using Humphrey Visual Field Analyzer was done, and MRI of brain was done for confirmation of posterior circulation infarcts, and assessment of systemic comorbidities was also done. We had 29 patients in total identified with homonymous hemianopia. 2 patients declined for further investigations. 8 were lost to follow-up, and of the 19 patients, 1 was diagnosed with occipital glioma in MRI and was excluded from the study. Of the total 18 patients identified with posterior circulation stroke, there was a male predominance of 94%. Most common age group was between 61 to 70 years. 56% had complaints of decreased vision, and other complaints included headache, giddiness, diplopia, field effect, imbalance, etc. 67% patients had left homonymous hemianopia. 28% had right homonymous hemianopia, and 1 patient presented with sectoral quadrantenopia. MRI showed 56% with right occipital infarct, 33% with left occipital infarct. 1 patient had small vessel ischemic changes, and 1 person was normal. 28% each patients had diabetes and hypertension, and there were other comorbidities like dyslipidemia, cardiac complaints, etc. Discussion: the eye is a window to the brain, and a thorough ocular examination will assist the clinicians to understand the mechanism of acute neurological deficits, and our study highlights the critical role of ophthalmologists in the early detection of posterior circulation stroke, especially when patient present primarily with visual symptoms. This aligns with broader observations. A study by Chaco et al. Had 710 new patients with 9 newly diagnosed CVA, 7 homonymous hemianopia, and 2 transient visual obscuration, and this underscores that posterior circulation stroke commonly present first to an ophthalmologist. Majority of patients were elderly males with commonest risk factors like hypertension and diabetes, consistent with known vascular sex difference and risk profiles. Several studies have reported a higher stroke prevalence among men, and may be due to the greater risk of hypertension, diabetes, dyslipidemia, and smoking in men compared to women. Visual complaints including decreased vision, headache and visual fields were seen in the study, and this reflects findings from prospective cohort studies. Homonymous hemianopia was confirmed to be the most common visual impairment after stroke, particularly associated with occipital, parietal and temporal lobe infarct. A greater occurrence of left-sided homonymous hemianopia was observed in our study, and this was noticed previously as well and may relate to hemispheric dominance and vascular anatomy of visual pathway. And one patient in our study presented with supranasal quadrantinopia, and this shows that incomplete and atypical field defect can still have a cerebrovascular etiology. MRI findings in our study revealed that occipital infarct in majority of patients, and this finding coincided with other studies where occipital infarct was found to be the most common MRI finding. This reinforces our observation that occipital lesions are the predominant finding on MRI in posterior circulation stroke patients presenting with visual symptoms, and reaffirms the role of neuroimaging in confirming the diagnosis. High prevalence of systemic comorbidities such as hypertension and diabetes reinforces the association between vascular risk factors and stroke. Multiple morbidity factors further complicates the clinical picture, especially in elderly patients, and necessitates an integrated care between the neurologist, intensivist, and ophthalmologist. Findings of our study affirms that ophthalmologists should maintain a high index of suspicion for posterior circulation stroke when patient complains of decrease in vision with a normal visual acuity on Snellens, especially when accompanied by subtle neurological complaints. Automated perimetry can serve as a clinical screening tool and can guide in timely neuroimaging and neurology reference, and helps in better patient outcome through early intervention. The limitations of our study were that we had a small sample size with single center setting and loss of follow-up of patients, and incomplete MRI data of some patients could introduce selection bias. Recommendations are that multi-center prospective cohorts is necessary to validate laterality trends and demographics, and implement routine perimetry screening in your ophthalmology clinics with rapid MRI referral pathways, and educate ophthalmologists and primary care physicians to recognize visual alarm signs for stroke. Conclusion, our study reinforces the indispensable role of ophthalmologists in identifying posterior circulation strokes. Timely recognition of visual field defects, especially homonymous hemianopia, followed by urgent neuroimaging and neurological referral, can markedly influence patient outcomes and ultimately reduce morbidity and improve patient prognosis. These are my references. Thank you.
Thank you, Doctor. Very interesting presentation, especially with regard to the laterality. Okay, so this is quite a straightforward presentation with occipital infarcts.
Yes.
And so, were you able to look at patients who had other features of stroke, like they might have been admitted elsewhere, or because it doesn't always present as a posterior cerebral artery infarct always. Many times it could be a middle cerebral artery and a posterior cerebral artery infarcts. So did you have any patients who was at a hemiplegia or something, who also had a simultaneous field defects and who presented to you later?
No, we would have had, like in the hospital, we have had patients like that, but in the study, we included
not.
those presented first to the ophthalmologist.
First to the ophthalmologist.
First to the ophthalmologist.
Okay. So, and you have listed out all the other known variables, very nice, hypertension, diabetes, and other things as risk factors. Did you make a study or did you make the analysis for smoking? You have mentioned it in your presentation, but did you make an analysis, because it significantly contributes to the increases the risk factor manifold. So were you able to analyze the data? No.
No, sir, because since this was a retrospective study.
Retrospective. Okay. So it would have been useful to
Yes,
get
sir,
that
if it
data,
was
because diabetes, hypertension is okay, but then the smoking increases the risk manifold in the presence of diabetes, hypertension.
Yes.
So those risk factors should be clubbed and seen.
Yes.
And the other thing is, where was the infarct present in that supratemporal defect location? Do you remember? No. So where do we expect it? It's typically we describe it as a pie in the sky. So which location, which lobe? At least temporal lobe. So you don't remember which in that particular case. It doesn't matter. Okay. And the most important thing is how many were missed by any other ophthalmologist, because these patients typically do not present as field defect. They just present as that side I am not able to see. And the vision will be 6/6, and many times
Yes,
ophthalmologists will say that everything is normal for you because pupils are normal, fundus are normal.
That
It will
is
be
why-
useful to look into that's why.
That's why if patients complain, and even if the vision is 6/6, we have to at least check their fields.
If the patients complain, we need to look into it.
Yeah, good presentation. So apart from the field effects, what were the other ophthalmological signs that you had elicited in these patients? Apart from field effect. Apart from the field effect, did you discover any other findings in these patients?
Mentioned infarcts were seen in the brainstem also in your presentation, if I remember. Elsewhere also, I think there is a mention in the
Yes.
this thing. So in that case, what would you expect? That's what
Yeah.
she is asking.
No, yeah, because you could be getting some gaze palsies and isoporias, and you need to look at
We had checked the pupil assessment was done.
yeah, that's what I'm
routine-
asking, because sometimes other findings may also be there. Visual field effects is one thing. Apart
yes,
from
ma'am.
that, you may get gaze palsies. I think sir would be able to tell
About
better.
giddiness
Yes.
and other things you had mentioned. That giddiness could be also due to other brainstem
Brainstem.
lesions and other gaze palsies like vertical gaze palsies and other things, Q deviations.
Q deviations.
Those
yes.
things could have been present. So posterior circulation stroke, by and large, the majority is the field effect, but then you will also be, so you should be taking a larger sample size.
Yeah,
to
larger
look
sample
at it.
size, and also look into the other things which may also be there in this patient. Another thing is acquired CVI, that can also be there. So I think you need to elaborate on the questionnaire a little bit. Thank you.
The next one is Dr. Trisha Yadu.
A very good morning, everyone. The title of my paper is Twice Daily 0.01% atropine slows progression after once daily failure in the myopic children. We have no financial interest in this study. So why does this myopia crisis matter? We know that myopia is escalating globally, and increase in myopia leads to many complications like maculopathy, glaucoma, and retinal detachments. So there are many options that we have. We have low dose atropine, peripheral defocal spectacles, ortho-K lenses. So 0.01% atropine is very commonly used, but the clinical dilemma when it fails amongst clinicians is whether to increase the concentration. But when we started this study, higher concentrations were not available in Indian market, or to increase the frequency. There is very limited evidence for the latter approach, and our study addresses this. So purpose of our study was to compare once daily therapy versus twice daily BD therapy in controlling myopia progression. Our inclusion criteria was myopic children who continued to progress on once daily therapy and who had good compliance to low dose atropine. We excluded all the children who had poor compliance, any other ocular pathology, they were on, or the patients who were on any other myopia control measures and amblyopia. This was a prospective single-arm study done between 2021 to 2025 at a tertiary eye care center. So this study was done across two time frames. T1 was the baseline when the patient was not on any atropine. Then T1 to T2, the patient was on HS atropine. And T2 to T3, the patient was on twice daily dose of low dose atropine. These are the demographic details of the patients. The mean age was 11.21. The females outnumbered in our study, and we had equal contribution by both the eyes, that is 38. The primary parameters we assessed were eggshell length and spherical equivalent. The secondary parameters we assessed were near point of accommodation, near point of convergence, and pupillary diameter. The significant progression was defined as per ATOM study, that is eggshell length elongation of more than 0.1 mm per 6 months and spherical equivalent change of more than 0.25 diopters per 6 months. So this table comprises of the results. From T1 to T2, the change in pupillary diameter during the first phase was 0.01. And during the second phase, it rose up to 0.21, which the change was statistically significant according to Wilcoxon test. And the change in eggshell length from T1 to T2 was 0.15. However, in the second phase from T1 to T2 to T3, the change in eggshell length significantly dropped to 0.08. Similarly, change in spherical equivalent in the first phase was minus 0.33 diopters, and it significantly dropped to 0.01 diopters in the second phase, which was also statistically significant. So we got all these three parameters to be statistically significant.
In our study, the distribution of myopia was almost similar in all the mild, moderate, and severe subgroups. This slide shows that when the patient, the yellow is denoting the OD phase. When the patient was on OD phase, the rise in the spherical equivalent of more than 0.25 diopters was seen in about 66.7% of the patient, which dropped to about 20% when we switched these patients to BD dosing. Similarly, the eggshell length rise of more than 0.1 mm per 6 months, which was about 72% in the first phase, dropped to 32% after twice daily dosing. The functional measures, this is the diagram showing accommodation and pupillary parameters. We all can see that during BD phase, that is the blue graph, they are a bit higher, means there were change in accommodation and pupillary parameters, but none of the child reported any visual blur, reading difficulties, etc. So while assessing that which parameter responded better, was it eggshell length or the spherical equivalent, we saw that both parameters changed, but there was significant reduction in the spherical equivalent. It almost plateaued. This is the subgroup analysis, which shows that these lines and the dots are overlapping closely. Means there was not much significant difference amongst the subgroup, both for eggshell length as well as spherical equivalent. So how this study aligns with the published evidence? Our study mirrors global evidence supporting twice daily 0.01% atropine. Similar to He et al., our post-intervention phase showed significant reduced eggshell elongation. Spherical equivalent progression almost plateaued after BD intervention, which is consistent with Zhu et al.'s BD benefit. So I would like to say that twice daily 0.01% atropine controls progression where once daily fades. Also, significant reduction in eggshell length and spherical equivalent progression rates was seen. Accommodation and pupillary function were preserved. No adverse effects were reported by the children. This study is consistent with emerging BD atropine literature. However, it is a non-randomized randomized sequential design, and adherence was not objectively tracked. It's a single center, and our sample size was modest. So this is first Indian study assessing 0.01% once daily low dose atropine in documented progressors. It's simple, it's accessible, as well as cost effective before switching the patient to other expensive measures like peripheral defocus glasses. Also, we need more randomized trials, a longer follow-up, and comparative studies of concentration escalation versus frequency escalation. So my take-home message from this study would be twice daily escalation effectively slows progression. It's a safe, practical, and accessible in Indian practice. It can be useful next step before increasing the concentration. Also, it provides first real-world Indian evidence for frequency escalation. Thank you.
There has already been many studies in this regard on twice daily atropine. So you're saying that it is specific to the Indian population.
Yes, ma'am.
Okay.
South Indian population.
And when you ask them to put in the morning, is there any special instruction that you will give the children?
Usually, ma'am, we advise only with punctal occlusion, not any specific instructions were given.
Okay.
Other than that.
And how will you taper this after when you decide to taper? Which will you like to taper, the morning one and the night one?
Ma'am,
And
we
have you tried it?
No, ma'am, we haven't yet looked into the tapering, whether should we taper the morning dose first. We usually taper the morning dose because HS is studied better. There is not much evidence on the morning dose, so we would like to taper the morning dose. We usually taper the morning dose in that.
Thank you.
Just one question. You spoke about the change in pupillary diameter. So, do you discontinue the drug and look at the pupillary diameter? How do you check? Because if the patient is on atropine, the pupil is atropinized,
Yes,
and
ma'am.
it's dilated
Exactly.
pharmacologically. Then how do you check?
Ma'am, in the same way only, routinely we'll send for the patient for pupillary diameter evaluation. We
So,
won't
do you
be
have
stopping
any
the drug.
pupillometer with you?
It's done on LensStar LS900, ma'am. It gives the pupillary measurements also.
The next presenter is Dr. Namita Viji.
Repaper is on predictors and prognosticators of consecutive esotropia after undergoing intermittent exotropia surgery. Consecutive esotropia is a manifest inward deviation developing in a formerly exotropic patient after surgical treatment for exotropia. By convention, more than or equal to 10 prism diopter EG persisting for near or at distance more than 2 weeks after exotropia surgery is considered to be significant. An initial overcorrection after intermittent divergent spin surgery is preferred. However, if it persists for more than 2 weeks, we go ahead with the conservative measure, and if the conservative measure fails, we go ahead with the surgical management. Hence, a thorough history and a good workup with looking into the old photograph, previous surgical summary is needed to plan a consecutive strabismus. Here, we aim to evaluate the clinical features and factors responsible for the onset of consecutive esotropia in patients who underwent surgical correction for intermittent exotropia. It was a retrospective EMR analysis done in all patients presented to the pediatric ophthalmology clinic with the diagnosis of consecutive esotropia from period 2013 to 2024. Previous surgery data was retrieved from discharge summary, photographs, and from the EMR. All patients underwent a detailed ophthalmic evaluation. These are the primary surgery parameters we looked into, that is age at initial surgery, what was the type of exotropia, angle of deviation for distance and near, amount of the primary surgery, and whether the surgery was unilateral or a bilateral LR recession. Among the consecutive esotropy parameter, we looked into any presence of refractive error, any complaints of diplopia, any presence of amblyopia, abduction limitation, any presence of high AC by ratio, oblique overaction with the pattern. And also we looked at the position of laterectus intraoperatively. All patients were given conservative management, and if the esotropia persists more than 3 months with more than 15 prism diopter, we went ahead with the surgical management. And if the angle of deviation was less than 20 prism diopter, we did only one laterectus advancement, and if it was more than 20 to 25, we did either bilateral LR advancement or unilateral LR advancement with MR recession, depending upon the distance near disparity. Coming to the results, most of the patients were less than 10-year age with a mean age 8.33 years. Females outnumbered in our study. Coming to the primary surgery parameters, 4 out of 15 patients had surgery done elsewhere with a mean age 5.86 years, with 66 patients were less than 5 years. Angle of deviation was almost similar for distance and near. None of them had any significant distance near and disparity. Average LR recession was 6.76. 20% had undergone bilateral inferior oblique recession along with the primary surgery, and majority had undergone bilateral laterectus recession than a unilateral recess resect procedure. Coming to the consecutive esotropia parameter, majority of the patients presented within 3 months of onset of consecutive esotropia, and most of them had a intermittent squint and a manifest squint, and angle of deviation was almost similar for distance and near. Coming to the BSV, 20% had diplopia and 40 were suppressed, and hypermetropia predominated, followed by emetropia and myopia, and 13.33 had amblyo, and 13.33 had high AC by ratio. Inferior oblique overaction percent 20%, none had DVD, abduction limitation 26.4%, and 2 had slick LR muscle. And coming to the management, 26.66% were better with the non-surgical management, and 66.66 required surgical management. Of the non-surgical management, 13.33 were better with hypermetropic correction alone, and 13.33 with high AC by ratio was better with bifocal. Among the surgical management, 60% required unilateral LR advancement, and 6.66% required bilateral LR advancement. One patient now study had lost to follow-up and presented with large angle ET of more than 50 PD ET and was sent for pediatric neurologic evaluation. These are a few cases. A case of a child with intermittent exotropia, post bilateral LR recession. She developed consecutive EP and underwent left LR advancement, and she is doing good. This child present on postoperative day 5 with large angle EP with abduction limitation and palpebral fissure changes, diagnosed as slipped LR and taken for exploration of LR with LR advancement on the next day, and she's doing good. This is another child who had a ET4 near and had found to have high AC by ratio. He's doing good with bifocal. So we found that after all the conservative and surgical treatment, 66.66 patients have regained fusion. However, 13% remain suppressed. Coming to the discussion, younger age at initial surgery because of the immaturity of visual function can lead to consecutive EP. Bilateral LR recession, where LR being the divergence muscle, weakening of the same along with the strong fusional convergence of the young child can lead to a consecutive esotropia. High AC by ratio, because of the poor population, the young child was almost always missed. Amblyopia, because of the imperfect binocularity, can amplify a small posture of overcorrection. Missed oblique overaction during initial surgery can lead to an overestimation of exotropia angle, can lead to a posture of overcorrection. Inferior oblique recession along with the primary surgery, as obliques are abductors, weakening of the same can produce an ESO drift. Also, consecutive EP of large angle on immediate posture period, have to think about slip muscle. To conclude, younger age less than 6 years and LR recession of more than 6.5 mm, high AC by ratio and amblyopia are the main risk factors we found in our study. So exercise caution with LR recession more than 6.5 mm young IDH users, as weakening of the divergence in those with strong fusional convergence can trigger consecutive EP and compromise binocularity. In young IDH patients, always go conservative, undercorrect, don't overcorrect. These are the limitations.
Thank you. And the findings are quite important findings that you need in such papers. Most of these cases are operated in your center or they are referred from elsewhere?
Four patients only operated, initial surgery operated elsewhere. Consecutive EP surgery was done at our center.
Okay, so most of the patients were operated in your own center. Yeah, so because I asked, as the average months of intervention was 3 months post initial surgery.
Yeah, that's the time they presented to us.
Okay,
some had lost to follow up. Initially, when they are looking ortho, they missed to come for the frequent follow up, and once later on they comes with the complaints of EP, the twins reappeared. The presentation was little late.
Yeah, so the important thing will be to look at the immediate post-op, and if there is any suspicion, sometimes these very young children, it is very difficult to get the correct measurements on the first post-operative day. So it is, if not able to get, then it is better to call them within a week or two and then reassess again, because many of the patients have went into suppression. See, most of the patients in intermittent exotropia are binocular, all of them I would say. This amblyopia was also listed as one of the confounders. Usually intermittent exotropia by itself will never cause amblyopia. So it must have been some added refractive error component or something like that. Some anisometropia must have been there. So if that is the case, then always correct the amblyopia first and then proceed towards the intermittent XT correction. But otherwise, I feel the only part was the intervention should have been much more hurried to regain binocularity.
Should call the next one, Dr. Ranjini H.
Good afternoon to all. So my paper is on clinical manifestations and management of strabismus in patients after orbital fractures. So strabismus after orbital trauma is reported to be in 58% of population, and most of them are caused by road traffic accidents. If we classify these fractures based on the location, they can be classified as orbital floor, medial wall, lateral wall, and orbital roof fractures. So the aim of my study was to study and evaluate the clinical features and management of patients with strabismus following orbital fractures. Ours was a retrospective clinical study, and data was retrieved from the EMR of the patients who presented with strabismus and double vision after orbital fractures. There were total 32 patients in our study. These were the parameters which were evaluated. So coming to the results, the mean age was 29.63 years, and there was male predominance. Left eye was the most commonly affected eye. Coming to the visual acuity, the affected eye visual acuity ranged from no perception of light to 6/6 vision with a mean log VAR of 0.09 2 patients had very less vision, no perception of light, and 636, and these were the patients who had sensory exotropia. Coming to the types of fractures, as we can see, majority of them had floor fracture, and in this group there was a distinct subgroup called as the trapdoor fracture, in whom the bony after the floor fracture, the bony fragment will recoil back and potentially entrapping the intraorbital contents. We also had combined fractures involving more than one wall. Coming to the etiology of strabismus, so we classified them as 2 groups. The first group was directly caused due to the orbital fractures. The common etiology was restrictive, followed by combined mechanisms, and we also had paralytic and sensory causes. But the other group were presented to us with orbital fractures, but the strabismus was not due to the fracture per se, but due to head injury or other polytrauma. So we had recompensated strabismus and cranial nerve palsies as well. Coming to the strabismus presentation, hypertropia was the most common presentation, followed by orthotropia, although these patients had variable vertical strabismus in up and down gaze, followed by hypertropia. We also had mixed presentation. And if we classify them, and in each subtype, again, restrictive was the most common etiology. Diplopia was present in majority of them, 81.3% of patients. Coming to the management, conservative management was given to 6 patients. Prisms were given to 12 patients, and majority of our patients underwent fracture repair with release of the entrapped muscle. And there were some group of patients who had persistent symptoms and strabismus even after fracture repair, and these were the patients who required strabismus surgery. So this boy presented to us, as you can see, left ptosis, limited adduction, elevation and depression, improved very well after intake of 6 weeks of oral steroids. So he also had a post-traumatic third nerve palsy with fracture medial wall. Prisms, as I mentioned before, was given to 12 patients, and these patients were with small angle strabismus who were able to fuse with the prisms. And majority of the patients underwent fracture repair with release of the entrapped muscle. Their main concern was limited ocular motility and double vision, and ocular motility improved in 42.3% of the patients, and double vision was improved in 34.6% patients. So this boy presented to us with accidental injury to the left eye. As you can see, he has a left hypertropia. CT scan showed a fracture floor, and he underwent inferior rectus release with a floor implant, and his hypertropia improved, and he recovered completely after 8 weeks of oral steroids. As I mentioned before, but still there were some patients who had persistent strabismus and double vision despite the fracture repair and release of the entrapped muscles, and these were the patients who underwent strabismus surgery, and in these patients FDT and FGT played a very key role. And there were some patients who also underwent strabismus surgery unrelated to the orbital fracture. So this gentleman in the upper level had a roof fracture, had a left hypertropia, and he had a tight inferior rectus and FDT, and he underwent squint surgery and had a stable alignment after 4 years. On the lower panel, this gentleman actually had a head injury. He had a fracture, but then he had a sensory exotropia with hypertropia, and had a good alignment after 1 month of post-squint surgery. This gentleman, on the other hand, had a combined mechanism of strabismus. He had an inferior rectus entrapment along with the palsy. So as you can see in the first picture, he has a primary gaze left hypertropia with limited elevation and depression. And after release of the entrapped inferior rectus, his hypertropia worsened with unmasking of the inferior rectus palsy, and he improved well after the squint surgery. So as the mechanism of strabismus in our study could be classified as below: restrictive, paralytic and combined mechanism, but there were also sensory causes. We wanted to stress on the posterior orbital floor fractures, where even after the release of the incarcerated tissue, the paratic component is manifested, and there is an increase in the angle of the strabismus with persistent double vision and ocular motility association. Also, we had all the following associations which were there along with the strabismus due to orbital fracture per se. So I would like to conclude by saying that strabismus after orbital fracture has varied presentations with varied etiology, and there should be an individualistic approach. Although the most common cause is restrictive, we should also consider other causes like sensory, cranial nerve palsies and decompensated strabismus. Also, in the reference to the posterior orbital fractures, always rule out mixed mechanism because it is very essential to counsel these patients because early recognition and counseling will prevent post-surgery surprises. These are my references. Thank you.
Did you make a note of the, did you take into factor the pupils in these cases?
Yes, sir. A detailed evaluation.
Was that?
I
So
think
did that help you in differentiating any neurogenic versus a restrictive cause or coexisting restrictive as well as a neurogenic cause? So because that gives a lot of clues.
Yes. Cranial nerve palsy, third nerve palsy, sir. They may be pupillary. If there is patients with head injury, especially, we have to rule out causes, neurological causes of cranial nerve palsy. So especially it can be due to a trauma per se. There can be also loss of iris sphincter tear, and it can be due to cranial nerve palsy, third nerve. So
it is really difficult for you to differentiate exactly what each factor contributes.
Yeah, in the same cases where you find a pupil anomaly, pupil abnormality, it is very difficult to get fusion also. Like after we try to intervene, how many cases were there with the pupil anomalies?
Pupil anomaly, a third nerve, as I mentioned, ma'am, there were 3 cases, and there was a mixed third nerve with sixth nerve. So yes, it is difficult, but then there are some signs which will rule out whether it is really due to trauma, anisocoria due to traumatic pupillary, or is it due to a cranial nerve palsy.
Yeah, more than that, diagnosis one thing, I'm also talking about the effect of our therapy. So the cases where you have anisocoria, it is very difficult to make them see single because the quality of vision becomes different. So even though they may read 6/6 or whatever, it is difficult to get a fusion endpoint. That is one thing. Another thing is how many of the patients had torsion?
Torsion, superior oblique palsy, we had 1 patient, ma'am, and decompensated strabismus. That was actually a decompensated superior oblique palsy. So 2 patients.
Okay, so because then you are a lucky series because the presence of torsion again will be making the management part very difficult.
This was unilateral torsion. Generally, you are telling about the head injury, they will be more of a bilateral superior oblique palsy. These were all unilateral.
Yeah, but sometimes the orbital fractures itself, because the globe gets dislocated, so there will be torsion. It need not be only in the case of a superior oblique palsy. The fact that the orbit has got fractured will itself create a torsion. But was it checked in all the patients?
Yes, ma'am.
Thank you.
The next presenter is Dr. T.R. Jacob.
Good afternoon, everyone. My study is on IOL prediction errors in eyes with axial length less than 22 mm, a retrospective study. Prediction error is the difference between the predicted post-operative refractive error and the actual achieved post-operative refractive error. Short axial length eyes remain challenging for IOL power prediction because small errors in effective lens position estimation translate into disproportionately larger refractive surprises. My aim was to compare IOL prediction errors of SRKT and Barrett IOL formulas in eyes with axial length less than 22 mm. My study sample included patients aged more than 18 years who underwent cataract surgery, both SACS and phacoemulsification surgery, although 90% of my cases were phacoemulsification surgery. A total of 120 eyes were selected. In that, it was divided into 60 eyes with axial length 20 to 22 mm and a control group of 60 eyes with axial length 22 to 24 mm. And each groups was subdivided into 30 each with the IOLs with SRKT formula and 30 with Barrett's IOL formula. And the exclusion criteria was the combined procedures like trabeculectomy with cataract, SOR with cataracts were excluded, and any combined procedures with cornea procedures were also excluded, and the post-operative best corrected visual acuity less than 6/9 were not included, and any cases with intraoperative complications were also excluded. This was a retrospective study which was done in a tertiary eye care center in Kerala. The cataract surgery was done by a single surgeon in the period of 2021 to 2024, and preoperative data was obtained from the optical biometry done before cataract surgery, and the spherical equivalent for the IOL power used for each surgery was noted. Post-operative subjective refraction at 2 weeks was assessed, and the prediction error was calculated by the difference between predicted spherical equivalent and the spherical power of post-operative subjective refraction. And coming to the results, we can see in axial length less than 22 mm, there is a significant predictive error, statistically significant difference in the predictive errors between Barrett's and SRKT formula. And in the axial length greater than 22 mm, there is no much significance in predictive errors. There is no difference. And in the group of SRKT, the eyes with SRKT IOLs, there is a statistical difference between the axial length less than 22 mm and more than 22 mm. But in Barrett's, there is no much difference. This is the line diagram showing the trend of prediction error. The orange line indicates the SRKT formula and the blue line indicates the Barrett's formula. We can see as axial length increases from 20 mm to 24 mm. The SRKT, the prediction error in SRKT formula decreases, but in Barrett's there is no difference. So the Barrett formula demonstrated lower and more consistent prediction errors across both short and long eyes, wherein SRKT formula showed a higher error in short eyes, indicating that Barrett performed better in eyes with short axial length. So coming to the discussion, in a larger short eye series with axial length less than or equal to 22 mm, Project Hyperopic Power Prediction reported that many earlier generation concepts, including SRKT, tended towards myopic outcomes, whereas newer methods mitigated this bias. Srivastava et al. Found that in axial length less than 22 mm, newer formulas outperformed earlier ones. The SRKT showed larger errors than contemporary options. A recent review synthesizing short eye evidence reached similar conclusions. Short eyes are at particular risk of myopic prediction error with older formulas. Performance improves with formulas that better model effective lens position and use additional anatomical inputs. My limitations were the number of eyes included was limited, which may reduce generalizability of the results. Being conducted in one center, the outcomes may not reflect wider population variations. Only two formulas, SRKT and Barrett universality formulas, were analyzed, whereas newer formulas like Hill RBF, Kane, EVO 2.0 could have provided broader insights. By doing this study, we came to the conclusion that although no single formula can be considered universally optimal in eyes with axial length less than 22 mm, Barrett University appears to provide a practical advantage over SRKT and should be preferred when managing short eyes. Our findings reinforce that short eyes require careful formula selection, and constant optimization and individualized formula choice remain essential to minimize refractive surprises in short eyes. Thank you.
These patients?
No, ma'am. Mature base scans were not there. The fundus evaluation was only done.
Okay. The importance of doing the base scan is looking at the RCT thickness, and we also look at the extreme eyes, we call them, as very short eyes and very long eyes. So we do a B scan, and axial length again less than 22. We are always careful with eyes less than 18. Okay.
Extremely low was not there, ma'am. Less than 20 were not there.
You didn't have, or you didn't check?
We did have, but it was very, like, I couldn't get it as a sample. Like 20 to 22 were only included in my
Included study. Means you never had patients less than 20?
We had, but I mean, I didn't include those.
So then short eyes, you can't call them as short eyes.
Like larger short eyes, like.
Because the title is only less than 22
22
millimeter.
mm. Only 20 to 22.
Yeah, it could have been classified as maybe 18 to 20 and 20 to 22. So, yeah, that's what.
So why did you not use Hoffer Q as a comparison? Because usually, traditionally, we say that is more accurate in short eyeballs.
Hoffer Q, it is said Hoffer Q is more accurate. But ma'am, my surgeon, like, it was a retrospective study. So the surgeon which I took SRKT as a better formula. And I just went through the Hofer Q calculations also. The IOL powers were almost comparable, like maximum 0.5 difference was coming, the difference of IOL powers. So, but I didn't make an analysis on that.
Thing is the generation of the formulas, whereas you club the SRKT and Hoffer and Holiday and all into the older formulas, whereas Barrett's is a newer generation comparatively, and then further down is the Menon. So when you compare, ideally it could have been between Hoffer Q and Barrett's. No, SRKT. Okay, yeah, if that way, because between SRKT and Hoffer Q, we know that Hoffer Q is better. So when you compare Hoffer Q with Barrett's, you will know whether Barrett's is still doing better. So in which your center, you are placing the IOL based on which calculation?
Barrett's formula now.
Barrett's. Yeah. So
Previously
universally, many centers have totally shifted to Barrett's in the adult intraocular lenses. So I think then that comparison might have been more useful.
This is done like with the 2021-22 SRKT was preferred at that time. Barrett's were not into use. So now after 2022, we started using Barrett Universal too. So I made a comparison like that.
Okay. Thank you.
Good afternoon. My study for presentation today is awareness and use of codes guidelines for ocular TB among ophthalmologists in Kerala. TB remains a major public health challenge in India, both pulmonary and extrapulmonary disease. TB uveitis is an important cause of infectious uveitis. Its different manifestation and clinical signs often lead to diagnostic uncertainty, delayed initiation of ATT, and variable treatment outcome. To address these challenges, CODES, the Collaborative Ocular Tuberculosis Study Group, developed a consensus-based guidelines aimed at standardizing diagnostics and therapeutic approaches. They also have an online open access digital tool. Both the guidelines and calculator provide recommendations on when to initiate ATT, considering both systemic and ocular findings into decision making. The aim of my study is to assess the awareness, understanding, and clinical application of CODES guidelines among ophthalmologists in Kerala, and to identify perceived barriers to their implementation in clinical practice. Going to the materials and methods, it was a cross-sectional anonymous questionnaire-based survey conducted among ophthalmologists practicing in Kerala across various subspecialties and institutional settings. A structured online questionnaire was developed using Google Form. The questionnaire link was distributed electronically through professional ophthalmology groups and academic groups, and participation was voluntary. No identifying personal data were collected to ensure anonymity. Responses were collected over a period of 3 months. A total of 219 ophthalmologist responses were obtained. The Google Form platform provided automated response summaries in the forms of tables and charts. Data were further compiled in Microsoft Excel and analyzed using descriptive statistics. The results. A total of 219 ophthalmologists responded to the survey. Nearly all respondents reported managing uveitis patients in their routine practice. The majority were in the age group of 30 to 39 years. Most respondents were females, while 9.6 were males. With regard to ophthalmic experience, 41 had more than 10 years of experience. Subspecialty distribution showed that general ophthalmologists and retina specialists formed the largest group. In terms of practice setting, private eye hospital was most common, followed by academic institution. With regard to ocular TB, 52% reported rarely seeing presumed cases, 36% saw 1 to 3 cases per month, and 12% encountered more than 3 cases per month. The most commonly used investigations were Mando and chest X-ray, followed by IGRA, sputum gene expert or AFB, and HRCT test. The vast majority reported never initiating ATT empirically. Always a collaboration with pulmonologist or infectious disease specialist was reported by about 87%. Now, to awareness of CODES, consensus guidelines was limited, with 57.5% were unaware. The awareness of CODES guidelines was higher among retina and uvea specialists compared to general ophthalmologists, although the difference did not reach statistical significance. Among those aware, the main source of learning were CMEs, peer discussions. Understanding of this criteria, among those aware, the understanding of CODES criteria was complete in 47%, partial in 40%, and absent in 13%.
Among 93 aware respondents, 52% reported always using the guidelines. Awareness of Codes calculator was even lower. Only 34% had heard of it, of whom only 12% of total respondents actively used it. On a confidence scale of 1 to 5, most respondents reported a moderate confidence in using Codes calculator for treating TB uveitis. The most frequently reported barriers to using Codes guidelines were lack of time or resource for a complete workup and lack of awareness. Other barriers included institutional conflicts, concerns about ATT toxicity, and reluctance from infectious disease specialists. Going to the discussion, the diagnostic workup patterns were heterogeneous with heavy reliance on conventional tests like MANTO and chest X-ray, while diagnostics like interferon gamma release assay and high resolution chest CT were underutilized. Empirical initiation of ATT was infrequent among our respondents, suggested a cautious clinical decision making. Multidisciplinary collaboration with pulmonologist and ID specialist was high, but a guideline-based standardization remains incomplete. Few of the ophthalmologists also reported that a few pulmonologists refused ATT initiation when systemic TB was not demonstrable. Only less than half of the respondents were aware of the guidelines, and even fewer reported consistent application it in practice. Key barriers identified were lack of time, resource, and awareness. And the limitations are it had a limited sample size, therefore did not represent all ophthalmologists across different practice settings. It was self-reported, therefore there is a potential for recall and reporting bias, and it didn't evaluate the impact of guideline adherence on patient outcome. My conclusion are the awareness, understanding, and adoption of Codes guidelines for managing tubercular uveitis are below optimal levels. The key barriers were lack of time, resource, and awareness. The recommendations are, one is that a wider and targeted education initiative can be undertaken to improve awareness of Codes guidelines, especially among early career ophthalmologists and those in non-academic settings. Awareness can also be targeted to pulmonologists or infectious disease specialists to strengthen collaborative decision making. Also, as the Codes guidelines are complex to recall in routine practice, wider promotion of Codes calculator can greatly simplify decision making. Also, future studies can be done with a larger and more diverse study population to better capture practice variation. And also, studies need to evaluate whether increased awareness and use of Codes guidelines can improve diagnostic accuracy and better patient outcome. These are my references. Thank you.
Very good presentation, Shafija.
Thank you.
Not sure, I'm not also not very much aware of these guidelines. So among those who initiated the treatment, were they, did they tell the patients to follow up for any toxicity, vision loss or things like that? Because we have to be concerned about ethambutol toxicity. Was that included in that
Actually,
protocol?
in my questionnaire, it wasn't included. We just had a Codes guidelines, whether they are aware or not, or how many are using it in. But in our institute, we usually call the person every monthly to check vision and color vision. Initially, also before starting ATT, do a fundus and a field examination, and every month the color vision and field vision testing.
So you have done a good study. So when you elaborate it further, you can make that recommendation also.
Okay.
Maybe you can modify add your name to the Codes. This thing to have that follow up for ethambutol awareness toxicity also. Are they aware so that they don't miss out?
Thank you.
Good afternoon, everyone. My topic is Second Eye Syndrome True? A prospective study in a tertiary eye care center in Kerala. Cataract surgery is an invasive procedure, breaking the blood-aqueous humor barrier and increases the prostaglandin production. The patients, ophthalmologists have reported that patients often complain about more pain or ocular discomfort while undergoing procedures in their second eye while compared to the first eye. So the aim of our study was to compare difference in preoperative anxiety, patient perception of duration of surgery, postoperative pain and visual improvement following cataract surgery in first and second eyes. It was a prospective observational study done over a period of 6 months in a tertiary eye care hospital. We included patients with bilateral cataract undergoing consecutive cataract surgery under peribulbar block or topical anesthesia within 3 months interval by a single surgeon. We excluded those with different cataract rates, those with intraoperative complications, those with different duration of surgeries, those unable to subjectively score pain, anxiety, perceived duration or vision, and we could obtain a sample of 103. For each eye, the patients objectively scored the preoperative anxiety 2 hours prior to the surgery using the Amsterdam preoperative anxiety scale. The intraoperative patient cooperation was scored by the surgeon herself from 1 to 4. The postoperative pain was scored by the patients 4 hours after the surgery using a visual analog scale. And after the second eye surgery, we asked them to compare between the first and second eyes in terms of the perceived duration of surgery and also visual improvement on the immediate postoperative day. Moving to the results, the mean age of the sample was 68.1 plus or minus 9.5 years. The mean time interval between the two surgeries was 21.5 days, ranging from even 2 to 80 days. The average duration of surgery was 12 plus or minus 1.3 minutes. The proportion of patients who underwent surgery under topical anesthesia and peribulbar block was almost similar. And regarding gender, females predominated the sample by 61.2%. For the objective comparison between the two eyes, the patients reported that they had reduced anxiety, reduced postoperative pain, and also we could obtain better cooperation following the second eye surgery rather than the first eye surgery, and all these results were statistically significant also. Does gender play a role? Yes, it does. We could see that females had increased preoperative anxiety, had increased postoperative pain and poorer cooperation compared to males, but it was significant, statistically significant only for the first eye anxiety. Now, first or second eye, which was better? More than 50% of the patients reported that their experience with both eyes were almost similar. They had equal visual improvement, equal duration. But we are actually worried about this set of patients who reported that their experience with the first eye was better. They had better visual improvement. They felt their duration was shorter for the first eye surgery. And it is this set of patients who actually challenged the surgeon's confidence in spite of performing an uneventful surgery. Next, we studied in a correlation between the time interval between the surgeries and the preoperative anxiety. We could see that regardless of whether the interval is short or long, the preoperative anxiety varies widely. Also, we analyzed in a correlation between the time interval and cooperation for the second eye. We could see that increasing or decreasing the time gap between the surgeries does not significantly influence the cooperation for second eye. Moving to discussion, several studies have been conducted in various populations worldwide, and majority of them have reported increased pain for the second eye in contrary to the result we obtained. But even a few studies like the last one have shown no significant difference in pain and cooperation between the two eyes. Several hypotheses have been proposed for this. Firstly, the patients are more probable to feel less anxiety while paying more attention to the pain during the second eye surgery. Also, a drug tolerance to the anesthetic agent can develop so that when it's administered for the second time, it has lesser effect. Another theory is the first eye surgery might have given rise to sympathetic irritation, making the contralateral eye more prone to painful stimuli. One study has even demonstrated increased level of inflammatory cytokine, monocyte chemoattractant protein 1 in the second eye after the first eye surgery. So to conclude, adequate preoperative counseling prior to the second eye is mandatory as for the first eye. A worse subjective experience reported by the patient after second eye surgery should be anticipated by the surgeon. We recommend to include thorough perioperative anxiety and pain assessment into routine surgical evaluation and modification of the plan of surgery if needed, so that we can improve the healthcare services at reduced cost to get a happy doctor and a happy patient. Thank you.
Like, I'm not sure whether you included the data. You said there's no difference between, based on the time difference between the first eye and the second eye surgery. Did you include that?
Yeah, yes, there was no significant correlation.
There is no significant. You had included that data also. And also, okay. So you said there is a gender difference. So I mean, it may not be really a true difference, but then there are other aspects like you should subdivide it into maybe the age group of that patients and the educational this thing, whether they've understood what they've explained and other things. It's surprising that there's a gender difference. Sorry, other
That inflammatory markers are caused, then even after the second eye also, it must be even more, or what is the interpretation for that?
After doing surgery in one eye, even in the other eye, the inflammatory markers are found to be increased. We, one study have in this prophylactic naproxen, prophylactic NSAIDs have shown to reduce the effect of that inflammatory protein and have shown to be better effect.
Even even before the first eye. And what was the duration between the eyes?
It varied, ma'am.
Varied.
Even 2 days to up to 80 days. Maximum was 80 days.
And did that make a difference?
No.
It did not. Okay. Thank you. But I have always wondered about this factor. It really exists, and glad to.
just same surgeon. I had one experience where the patient complained to me after the second eye, and first eye doctor was better and he did it better. I had only done the first eye also. The patient didn't know that and complained to me that the first doctor was better. So this happens.
Happy patients don't acknowledge, only the unhappy patients complain.
Our next presenter is Dr. Chandrakant.
Good afternoon, everyone. Respected judges and friends. The topic of the day is the binocular battle, a novel approach combining trans-PRK and ICL for spectacle freedom. Introduction, as you know, the common refractive errors are myopia, astigmatism, and hyperopia. To relieve of these defects, you have spectacle correction, contact lens, then you got LASIK, laser, then ICL or intraocular polymer under lenses. This is a short video of photorefractive keratectomy, PRK. After topical application of anesthetic drops, you would do a trans-PRK examer laser, put mitomycin, thorough wash, put a contact lens. That ends the procedure, PRK. So this is a surface ablation procedure suitable for thin corneas, avoids flap-related issues. Only problem is little of pain is there, delayed recovery and possible haze. It is irreversible. Then next comes the implantable columnar lenses. A short video there. How this ICL is placed inside the cartridge. In the procedure, temporal incision. Under tropical anesthesia, this is performed. Side put incision. You implant the intraocular lenses. Then keep the haptics behind the iris. Here the posterior epic IOL, highly effective in eye myopia, suitable for thin corneas also. It gives an excellent optical quality and reversible procedure. Risk of cataract, IOP, raise and vaulting are certain issues. Ideal for candidates unsuitable for corneal surgeries. I just went to through the literature where there was a comparison between PRK and ICL, but I didn't get any literature or papers in the past. The objective of the study was to evaluate visual outcomes, safety, and the patient satisfaction in patients undergoing PRK in one eye and ICL implantation in the fellow eye, the same patient. The aim was to compare visual acuity outcomes of PRK and ICL in the same patient to assess refractive stability, safety, and complications, to evaluate patient comfort and binocular satisfaction. The study design was retrospective, observational case study. Study area was in cornea and refractive surgery department at Tertiary Eye Care Center. Sample size was 5 patients, 10 eyes. Here, 5 patients who underwent ICL implantation for high myopia, unsuitable corneal parameters in one eye, and trans PRK for low to moderate myopia with suitable corneal parameters in the fellow eye. Data collection, postoperative uncorrected corrected digital visual acuity, best corrected visual acuity, refractive stability, contrast sensitivity, complications, and subjective satisfaction. They analyzed at first week, first month, 3 months, 6 months, and 1 year. By selecting contralateral eyes of the same patient, the study aimed to minimize inter-individual variability and allow direct comparison of outcomes under identical systemic, genetic, and lifestyle conditions. Patient selection, the inclusion criteria, as I said, age is 25 to 40 years, stable refractive area for at least 1 year, high myopia, not fully suitable for bilateral corneal refractive surgery, educate anterior chamber depth more than 2.8 millimeter for ICL implantation, healthy corneal endothelium with adequate endothelial count, absence of ocular pathology like keratoconus, glaucoma, and retinal diseases. Exclusion criteria include previous ocular surgery, active ocular inflammation, or dry eye disease, systemic disease affecting wound healing like uncontrolled diabetes and autoimmune disorders. These are the pre-operative evaluation which are done: visual acuity assessment, anterior segment evaluation, posterior segment evaluation, corneal mapping, anti-chamber analysis, and dry eye evaluation. Surgical procedures I already explained the video. Postoperative follow-up was in the form of first week, first month, 3 months, and 1 year postoperatively. Here it was in the visual outcomes, uncorrected visual acuity, best corrected visual acuity, manifest refraction, contrast sensitivity was analyzed. The stability, the refractive error change, how stable it was. The complication include the IOP examination, the slit lamp examination, fundus evaluation, corneal length, anterior segment evaluation, visual comfort, night vision, overall satisfaction, whether there was glaze or halos, and dryness was also evaluated. These are outcome measures. Primary, the visual acuity. Then second, you have got comfort of the patient, post-operative complication, contrast sensitivity, and corneal endothelial health. The results. The visual acuity, and in the LASIK PRK group, we had a slower recovery. Visual acuity between 618 and 69 in the first week, improved to 69 by 1 month, first month. By 3 months, we had a visual acuity of 6 by 6 in these eyes. In the ICL group, we had rapid visual recovery, 6 by 9 in all eyes by 3 to 5 days, stable 6 by 6 in 1 week. This is a comparison of visual outcomes. If you can see the decimal visual acuity, the top of the graph is 6 by 6, the bottom of the graph is 6 by 60. Top of the graph is 6 by 6. The visual acuity in the form of a graph. Next, in the contrast sensitivity, mild reduction in contrast sensitivity in the first 3 months, especially in eyes with the trans and haze. Glaze and halos for more than 3 months, particularly in dim light. Symptoms decrease over time, but persisted mildly in one patient at 12 months in the LASIK group, LASIK PRK group. In the ICL, superior contrast sensitivity, especially under mesopic and low high light conditions in all follow-up visits. This is a graph. Bar chart showing night glare and halo severity. Pain in the LASIK group, moderate to severe pain and photophobia and tearing for the first 2 to 3 days post-operatively. In the ICL group, we had largely painless with only one mild foreign body sensation. Binocular and patient experience. Here in the early post-operative phase, disparity in visual recovery caused a temporary binocular imbalance in PRK group. From 1 month onwards, binocular function restored was normalized. By 12 months, all patients reported comfortable binocular vision, with some noting better night vision and clarity in the ICL eye. Complications in the LASIK group, one eye developed mild grade and one eye is at 3 months, resolved with topical steroids. In the ICL group, no cataract pigment dispersion was there, no cataract seen or raised IOP noted. Vault was well adequate in all cases. Discussion, as I said, ICL clearly outperformed the PRK in terms of speed and speed of recovery. Patients exhibit better visual function. ICL provided superior contrast sensitivity throughout the follow-up. PRK had significant early postoperative discomfort, a major limiting factor for patient satisfaction. Binocularity in the ICL group, in the early mismatch between eyes, fast recovery ICL and slow power PRK led to temporary binocular imbalance. The safety profile. Summary: ICL positives. Positive points are faster visual recovery, superior contrast sensitivity, greater patient comfort. Early glare negatives were early glare, procedure invasive, high cost. PRK group positive were few optical side effects, compare long-term outcome. Negatives were slower visual recovery and initial pain, and of course, greater patient comfort. When used judicially in the same patient, they complement each other and expand refractive surgical outcomes. Combined techniques offers a space, safe, effective, and customized solutions for patients residing with spectacle freedom when LASIK or bilateral PRK is not feasible or bilateral corneal procedures are contraindicated. These are my references.
Did you do PI in all cases of ICL, sir? Yeah,
No.
PI?
No.
You have not done.
We have not done.
If I remember, you selected in the same patient for different eligibility criteria. So would that have contributed to any difference in the outcomes? Because because of eligibility, like one were relatively shorter myopes and the other were relatively longer myopes. So the eligibility criteria differed in selecting the eyes within the same patient.
Yes.
So would that have any bearing on the outcome of the results? Preoperative factors.
Certain parameters we can't stick to a certain parameters because we need such patients, you know.
Yeah.
The cost factor is also there. When you ask for an ICL in a patient who has done a PRK in one eye, the cost is it may become 3 times the cost, 3 or 4 times also sometimes.
Okay.
So the parameters, as I said, the corner parameters and other things we are set a protocol based on that we proceed.
Okay, sir.
Sir, good presentation, sir. And what was the test for binocular vision which was done in this, sir? And was accommodation tested in all the patients before the surgery?
Basic protocols were done actually. All the basic protocols were carried on.
Because when we see the patients post LASIK, not related to this study, but generally when we see patients post LASIK, we find many myopes tend to have poor accommodation. So that may be one more reason for poor patient outcome and happiness post surgery. So that also.
Next presenter is Dr. Neenach Jose Rashid.
Good afternoon, one and all. The title of my study is Vertical Palpebral Fissure Changes After Supramaximal Horizontal Muscle Surgery, a Clinical Analysis. Large angle exotropia is often tricky to manage surgically, and in cases of exodeviation greater than 45 to 50% diopters, most strabismus surgeons prefer 3 or 4 muscle surgery rather than excessive recession or resection in one eye to avoid possible palpebral fissure narrowing and limitation of abduction. So our study the aim of our study was to compare changes in vertical palpebral fissure height before and after unilateral supramaximal medial rectus resection and lateral rectus recession for large angle exotropia, and to look for palpebral fissure asymmetry between the both eyes and to assess the patient reported cosmetic satisfaction. The study included 30 adult patients with exotropia more than 45 prism diopters who underwent unilateral supramaximal recess resect procedure at a tertiary eye care center in India between March 2024 and May 2025. 12 patients were in the age group 18 to 30 years, 12 were in the age group 31 to 50 years, and 6 were above 50 years old. 16 patients were females and 40 patients were males. 7 patients had congenital exotropia, 7 had intermittent exotropia, and 16 patients had sensory exotropia. And the preoperative angle of deviation ranged between 45 to 50 prism diopters in 8 patients, 50 to 60 prism diopters in 16 patients, and 60 to 65 prism diopters in 6 patients. All the patients underwent a standardized unilateral surgical protocol involving 10 millimeter lateral rectus recession and 8 millimeter medial rectus resection on the poorer seeing eye or non-dominant eye, and all procedures were done under local anesthesia via a lower conjunctival cul-de-sac approach. Chances of undercorrection and a possible need for secondary surgery was explained to patients with preoperative angle of deviation more than 50 prism diopters. A software-based image analysis of patients' photographs was used to measure the lid fissure height. The photographs were taken preoperatively, immediate postoperatively, that is within 1 week post-op, and 3 months postoperatively. The lid fissure height was then measured on the standardized photographs using ImageJ software. The average corneal diameter was taken as 11.5 millimeters, and it was used for calibration of the scale. This slide depicts how the images were processed in the ImageJ software. The average corneal diameter was taken as 11.5 and it was used to calibrate the scale. And this calibrated scale was used to measure the vertical palpebral fissure height. The key parameters analyzed were pre- and post-operative deviation in prism diopters, palpebral fissure height at multiple time points, and patient-reported cosmetic satisfaction at the end of 3 months. The mean preoperative deviation was 52.5 prism diopters. The preoperative vertical palpebral fissure height was 10.94 millimeters. These bar diagrams represents the change in lid fissure height. In the first diagram, we can see when we compare the preoperative lid fissure height value with the immediate postoperative lid fissure height value, there is around 1.22 millimeter reduction. And when the preoperative value was compared to 3 month postoperative, the decrease has come down to 0.22 millimeters, which indicates that the initial decrease was indeed transient. And when postoperative 3 month value was compared to that of the lid fissure height of the other eye, the difference was 0.2 millimeters, which was statistically significant but cosmetically negligible. Vertical palpebral fissure height exhibited a statistically significant decrease during the immediate postoperative period, with subsequent progressive normalization approaching the nearly approaching the preoperative measurement by the end of 3 month follow-up. At 3 months, the residual difference between the operated eye and the unoperated eye was 0.2 millimeters, which was statistically significant but cosmetically negligible. At 3 months, average residual exotropia was around 8 prism diopters, indicating a good surgical alignment, and patients reported a high cosmetic satisfaction with average scores of 4.5 out of 5. These sequential images show the changes in the lid fissure. We can see a decrease in the lid fissure height during the immediate postoperative phase, which then comes back to near normal stage. There are only a few studies done objectively looking at the palpebral fissure changes following unilateral supramaximal resect procedure. The key prior studies have found similar outcomes regarding transient lid fissure narrowing and high success rate for large angle exotropia. Our study adds new insights specific to Indian population. Supramaximal resect procedure is effective for large angle exotropia with minimal long-term lid fissure asymmetry. It is a safe alternative to multi-muscle surgery with an added advantage of having 2 horizontal muscles in the fellow eye spared. Our limitations include small sample size and lack of long-term functional outcomes. In conclusion, our approach offers predictable results with high patient satisfaction and minimal long-term lid fissure asymmetry. These are my references. Thank you.
Good presentation. Have you compared between the patients who underwent normal average levels of resect with these patients?
We have not, ma'am.
I think that there need to be 3 groups. So between the 2 eyes, and also you should compare between another, because see that one fact is it is improving. It is improving between the first post-op and the 3 months. So it could be just a factor of lid edema also. So even I think looking at the pictures, it looks like that. So if you want to negate the aspect of that, then we need to compare between, for the same surgeon, normal recess resect versus supramaximal recess resect, and then come to the conclusion of how much is the thing contributed just by the, definitely excessive can have this, but that will be also, you have to look between the primary right gaze and left gaze, because there will be narrowing in certain cases more than like Duane's. So if that's going to cause restriction, so I would like you to modify the study further on these accounts.
The next one is Dr. Anjana Nair S.
Good afternoon. I'm presenting in my paper Prevalence of Ocular Abnormalities in Children with Autism Spectrum Disorder. So the primary objective of my study was to determine prevalence of ocular and visual anomalies in students diagnosed with autism spectrum disorder and the effect of the interventions. It was done as a descriptive study conducted at the Tertiary Care Rehabilitation Center in the Central Kerala from June 2023 to June 2025. We included a sample size of 190 children with confirmed cases of autism spectrum disorder. Our team was a multidisciplinary team which consisted of a pediatric ophthalmologist, pediatric optometrist, developmental pediatrician, occupational therapist, clinical psychologist, as well as a speech therapist. We did a comprehensive evaluation protocol on every kid, starting from the demographic details, and we assessed the visual acuity using age-appropriate testing like Lee Symbols chart and Snellen's chart. Subjective refraction was done in all the cooperative subjects to determine the refractive status, and cycloplegic retinoscopy was done in all the 190 students. And we also included a strabismus evaluation, anterior segment evaluation, as well as a dilated fundus examination. So we classified the whole study group into two, as group 1 with the refractive error and group 2 with no refractive errors, and which was based on All India Ophthalmological Society consensus guidelines for pediatric review correction. For the study purpose, we defined the refractive errors as myopia with more than minus 0.5 diopter sphere or equivalent or subject refraction or equivalent in cycloplegic retinoscopy, hypermetropia plus or minus plus more than or equal to plus 0.5, and cylindrical component more than 0.5 diopter cylinder on subjective or cycloplegic retinoscopy was evaluated in the astigmatism group, and any child presenting with astigmatism more than 0.5 diopter cylinder or greater were included in astigmatic group for the analysis. So after the analysis, we found out that the mean age group of the population was 5.25 years, and it was a male predominant study population with 71.1% as males. We classified the students into different categories of severity of autism spectrum disorder into mild, moderate, and severe based on Indian scale of assessment of autism. And we found out that among the study population, 64.7% of students had abnormal visual parameters according to the IS guidelines, whereas 35.3% children had a normal visual parameters. We categorized into different subgroups of ASD, which again followed a similar pattern. All the subgroups of ASD were having a high prevalence of visual anomalies. And in our study, we found out that astigmatism was the most common refractive error found in the population, followed by hypermetropia and then by myopia. We evaluated the subgroups of ASD with respect to this refractive errors, and mild and moderate cases of mild and moderate categories of ASD followed a similar trend wherein astigmatism was the commonest refractive error. And additional findings that we could found out was we found 5 cases with strabismus, among which 4 were exodeviation and 1 was a esоdeviation. And all the children were given spectacle corrections according to the guidelines. And we saw that 19.55% students had an improvement in visual acuity after spectacle correction. So it demonstrated a significant clinical benefit in nearly 1/5 of the study population, confirming the importance of early detection and intervention. So coming to the discussion part, autism spectrum disorder is a neurodevelopmental disorder with prevalence ranging from 0.09 to 1.07 among the population between 0 to 17 years in India.
So in a study population conducted in South India, it revealed that the refractive errors and strabismus as the main ocular pathology in general population with the prevalence of 0.55% and 0.43% respectively. In the present study of refractive errors and strabismus was much higher in the study group when compared to the general population of non-autistic children. This indicates that the children with ASD have a very high propensity for developing refractive errors than the general population. So this is a comparison between the available literature trends. So it is very evident that our sample size was quite high, 190, and all the studies were not exactly dominating on the ASD part. They were also studying on the other parameters, but our study was mainly focusing on the children with autism spectrum disorders, and our study included all cycloplegic retinoscopy for all the study subjects, whereas it was lacking in the other studies. And the difference that we could found out in our study population was astigmatism was the highest, most common refractive error, whereas most of the other majority things were getting as hypermetropia as the most common thing. So as a conclusion, ocular abnormalities in children with autism spectrum disorder exceed the general population rate, requiring a very vigilant screening protocol. Optimal timing is very crucial, which enables adequate visual rehabilitation and better outcome, which improves the quality of life. Thank you.
Very nice study.
Thank you.
And wasn't it challenging to check the refraction for these children?
Yes, ma'am.
It would have been very challenging. So do you think they are compliant to using the glasses?
Most of the kids were compliant, but I think it needs an extrapolation on that part too. I considered that as a limitation of my study.
Okay, and one more thing is, do you think this astigmatism was caused by the rubbing? I mean,
There
sometimes
could be
these
one
kids
chance
that they
there could
might be
rubbing
rubbing
among
their
these
eyes.
children. And other thing maybe slightly due to the inclusion criteria that I included the patients with even 0.5 diopter cylinder was included in the astigmatic group. So maybe the inclusion criteria, I'm not sure whether it had
The methodology.
better, yeah.
So did you have a follow-up to see whether the refraction improved or remained the
Yeah,
same?
1 month follow-up.
Good that you have undertaken this study. And did you also look into the functional aspects of vision, like CVI?
No, we have not included that.
In future studies, you can look into that also, because I think almost 30 to 40% incidence of CVI is there in children with autism. And even with a good visual acuity, sometimes they may not be able to perform well. Okay.
Coming to our last presenter, Dr. Kiran Chandra. Vinita Vijay.
Today I'll be talking the optical coherence tomography characteristics in the acute stages of multiple evanescent white dot syndrome. So I'll be just displaying two fundus photos over here, of different patients. Both are young myopic ladies. So in the first fundus photo, you can see over here, it's barely it's a featureless retina, which only probably a dull foveal reflex. In the second fundus photo, the photo appears more obvious with numerous discrete yellowish white nodular lesions all across the macula, posterior pole, as well as mid-periphery, and optic disc edema. So both are actually, the presentation is mutes, and in the first fundus photo, if you correlate with the OCT finding, so the OCT across the foveal section shows outer retinal changes. So if fundus clues are subtle or confusing, OCT may actually help in diagnosing mutes before anything else does. So mutes is a rare, acute, and often missed entity among white dot syndromes. So it's on conventional examination, the findings are often subtle. And OCT is one of the earliest and most sensitive modality for early diagnosis with a good sensitivity. So by doing the study, we found distinctive and consistent OCT patterns in every patient. So this is a retrospective cohort study involving 8 patients with acute mutes. And by acute mutes, I mean a patient presenting within 1 to 3 weeks of the symptom onset. The complete multimodal imaging was done, which included color fundus photo and OCT, fundus autofluorescence, fundus fluorescent angiography, and indocyanine green angiography. And the main focus was on the acute stage SPOCT phenotypes and the recovery signatures. So follow-up ranged from 1 to 8 months. So these are the core acute OCT biomarkers studied.
that is a conical shaped hyperreflective material above the retinal pigment epithelium, linear hyperreflective columns in the outer nuclear layer, the disruption of the outer retinal bands, that is external limiting membrane, ellipsoid zone and interdigitation zone, and hyperreflective dots involving the vitreous, outer nuclear layer and the choroid. So over here it's illustrated on the NPAS OCT. These are different sections of the same macula of the patient. Hyperreflective dots in the vitreous can be seen numerous in almost all the sections. In the second section, you can see the linear hyperreflective columns in the outer nuclear layer. It protrudes from the ellipsoid zone and extends to the outer nuclear layer. And in the third section, an outer retinal hyperreflective mount can be seen exactly at the fovea. And in the fourth section, you can see what appears as the linear hyperreflective projection above the retinal pigment epithelium, and below it hyperreflective dots in the choroid. And in all the sections, patchy areas of ellipsoid zone loss are also well appreciated. So, ascribing to this, the typical mutes profile, most of the patients are females in the age group of 20 to 49. A majority of patients had a good visual acuity of 6.6 to 6.9, with only 3 patients falling into 6.15, 6.18 visual acuity group. And the patients are mostly mildly myopic, and symptoms included central blurring of vision and photopsia in all the cases. And all patients received a short course of oral steroids since they were symptomatic. So OCT features in decreasing order over hyperreflective dots in the vitreous, ELM disruption, EZ disruption, and IDZ loss in all 8 eyes. Hyperreflective dots in the choroid and conical hyperreflective projections above the RPE were seen in 7 eyes. Linear hyperreflective columns in the outer nuclear layer and hyperreflectivity in the outer nuclear layer were seen in 6 eyes. Hyperreflectivity involving the outer plexiform layer was seen in 4 eyes, and outer retinal hyperreflective mount was seen only in 1 eye. So these are the foveal sections of all 8 representative cases, which shows those findings clearly. The ellipsoid zone can be seen. Those areas or patchy losses of EZ can be seen in all the sections. The hyperreflective columns protruding the outer nuclear line can be seen at the fovea in some of these eyes. And vertical conical hyperreflective projections above the RP can also be appreciated clearly. So the ancillary imaging actually supported the diagnosis and involved fundus autofluorescence, fundus fluorescent angiography, and ICGA. The FFA actually shows early and late hypofluorescence. ICGA shows numerous nummular hypofluorescent spots persisting even into the late phase stages. And fundus autofluorescence shows a beautiful patchy areas of hyper-autofluorescent lesions around the fundus. Follow-up of follow-ups are available in only 4 eyes and of range of 1 to 8 months, and almost all eyes regained a vision of greater than or equal to 6/9 vision over this follow-up. And OCT characteristics showed a uniform sequential resolution, right? Hyperreflective dots were the ones who resolved first, accompanied by linear hyperreflective columns as well as conical hyperreflective projections. Coming to the outer retinal bands, ELM were the first to resolve, followed by EZ recovery, and IDZ were the last to recover among the outer retinal bands. Structural normalization was seen in 3 out of 4 eyes at the final follow-up. So here is a case of a 20-year-old female who presented with blurring of vision in the right eye of 3 days duration. The BCVA of 6/6. As you can see in the fundus photo, the fovea appears granular orange deposits can be seen in the fovea. And on montage CP, you can see a few discrete grayish lesions can be seen subretinally. OCT sections show only subtle ellipsoid zone loss. And in the third section, you can see a linear hyperreflective column protruding into the outer nuclear layer. Fundus autofluorescence shows the extent of the disease by numerous hyper-autofluorescent lesions. Follow-up over a period of 5 months actually showed gradual resolution of the ELM disruption and hyperreflective dots initially, followed by beautiful restoration of the ellipsoid zone, finally followed by the IDZ. And that changes can be seen in the corresponding FAF images as well. So these patterns occur because of something called as photoreceptoritis, that is photoreceptor inflammation involving the photoreceptor cell bodies. The outer nuclear columns and the conical hyperreflective projections are very typical of mutes. The delayed IDZ restoration is because of slow regeneration of the cone outer segment tips. Choriocapillary involvement are very subtle, that's why you see only subtle hyperreflective dots involving the choriocapillaries. So the clinical relevance of the study helps confirm mutes in the early stages and helps differentiate it from the other mimicking conditions like APMPP, acute placoid multifocal pigment placoid epitheliopathy, and other outer retinal inflammations. I've demonstrated a few DDs over here in the OCT. APMPP appears as a fluffy outer retinal hyperreflectivity with slight outer retinal thickening. PAC appears as a dome-shaped projections above the RPE. acute retinal pigment epithelitis, there's a hyperreflective thickening at the RPE and ellipsoid zone loss. Syphilitic outer retinopathy also appears as patchy areas of ellipsoid zone loss with granularity involving the above the RPE layer. OCT helps predict the recovery and reduces over-investigation. The final take-home message is MUTES has distinct reproducible acute OCT signatures. The conical RPE projection and outer nuclear columns are the key. Recovery follows a specific pattern involving the ELM, EZ, and IDZ. MUTES has got an excellent visual prognosis. So MUTES has specific OCT fingerprints. Once you see it, you will never miss it again.
Excellent findings you have showed. The only thing I have a doubt is like how much an early, which is not an apparent mutes, which is not visible clinically, ophthalmoscopically, how valid have you compared those findings and how much predictive are the OCD findings in those cases? What is the predictive value of those?
In this, 3 patients presented within 48 hours of presentation. So in one patient, out of those 3 patients, FAF was not able to even delineate those hyper-autofluorescent patches. OCT was very specific. It showed those in those areas of foveal granularity. In one example, I showed EZ was exactly disrupted in that area. And you see those conical hyperreflective projections into the outer nuclear layer and hyperreflected dots involving the OLM. So OCT is extremely sensitive and specific in the acute stages, specifically involving the time gap of 24 to 48 hours. Compared to FAF. FAF gives an extent of the disease burden, but OCT is very, very specific.
Thank you, doctor.
Thank you.